So good afternoon, everyone. I'm Dr. Anil Venkitachalam, a consultant neurologist at Reliance Hospital at Navi Mumbai. And I'm going to speak to you all today on the approach to headache disorders. So headache is a very common problem that we encounter on an outpatient practice. And almost everybody experiences patients who have a headache. You know, a lot of times these patients are like referred to the GPs, the physicians, then they also come to the neurologist. They also go to other subspecialties like pain, or they also go to their family doctor. So it's a very important disease that we have to manage. A lot of patients may present with headache, and we need to know how to manage this headache. So I'm going to start with an approach to headache, and let's see how to go about it. And like after the topic is over, then we'll have question answers, okay, which we are going to actually take from the audience. So the aims of this lecture is mainly going to be on an approach to headache, what are the patterns of headache, and what is the clinical diagnosis, how do you make a clinical diagnosis, and how do you treat these headaches. So as I told you earlier, headache is a common disorder. It can be classified as a primary headache. So primary headaches includes the migraines, it also includes the cluster headaches and the primary headache disorders. That means there is no other secondary cause that is involved. Or there could be a secondary headache. The secondary headaches are because of tumors, because of infections. It could be as a result of, space occupying lesions in the brain. It could be because of vascular malformations. Very rarely, stroke and vasculitis can cause headaches. So those are secondary causes of headaches. The general rule of the thumb is always that you rule out secondary causes and then you treat the primary causes. So that's the rule of the thumb. When we look at the commonest cause of headache across all populations, it's basically migraine. So, like migraine is a very common illness which is seen in the general population. And it is the most common cause of headache. It's a primary headache disorder. Just a minute. Yeah. So when we look at the pain sensitive structures in the brain, we can see that, you have the scalp, which is a pain sensitive structure. And then we have the blood flow changes which are there, but it's basically transmitted via the stimulation of the trigeminal nucleus, basically the ganglion in the trigeminal nucleus, as well as the thalamus. So basically it activates the trigeminal neurons and stimulates the thalamus, and the pain signals reach the cerebral cortex, and from there the output is relayed. So there is a big role of the trigeminal nerve and the trigeminal nucleus as well as the ganglion, for the manifestation of headache. So let's look at the common headache types that we see in our practice. So we can see basically this graphic which is there. So if you get pain mainly around the temples and front of the ears, it basically indicates a TM joint dysfunction. So that is basically a temporomandibular joint dysfunction, very commonly seen in the elderly, very commonly seen in people who chew hard food, etc. So it can be because of that. Also associated with like TM joint arthritis, which is again commonly seen with rheumatoid arthritis patients, osteoarthritis, etc. Sinus pains is typically egg-shaped. It's basically around the cheekbones here, and it's around the frontal region out here above the eyes. So this is like typically a sinus pain. So like remember the X in front of the nose. So it's around the cheekbones here and around the frontal region. Cluster headache is classically retroorbital. So it's basically behind the eyes that you can see the pain. These patients have pain. Then the tension type headache, that is usually like a band-like headache, which the patients actually complain of. So they have a band-like squeezing kind of pain over the head. Then you can have cervicogenic headache. So patients who have very bad cervical spondylosis or cervical radiculopathies, they have severe neck pain, which radiates, to the which actually radiates to the nape of the neck as well as the occiput, and there's more of a traction. And apart from that, you also have like migraine, which is very common. It's a throbbing kind of pain, generalized headache. It can be unilateral or bilateral, associated with vision changes, nausea, vomiting, and and like sensory sensitivity. So basically, you have multiple causes, and these are like multiple patterns of involvement. So how do you make the diagnosis? So if it's acute, always rule out an infectious cause like a respiratory infection or sinusitis, etc. If somebody says they have had an acute onset of headache, they've never had they've never had a headache in their life, then you need to rule out infectious pathology. If it's chronic, it's recurring again and again, you need to consider the various other causes. It could be a tension type of headache, it could be a migraine, it could be a combination of migraine and a tension type of headache. And very rarely, patients who have migraine, they transform. So they acquire stresses and triggers along the way, and the pattern of headache transforms. So this is also called as a transform migraine. Then you need to realize that there are certain serious disorders which you shouldn't miss out. You should never miss out a subarachnoid headache. So that's like a thunderclap headache. So that's basically the worst headache of their life. The patient would actually complain of. It's as if somebody has hit the head. It's like a strike of lightning. It could be a dissection. Temporal arteritis in the elderly. It's again a very serious condition, easily treatable, with steroids. Venous sinus thrombosis, again seen in the younger individuals, people who are alcoholics, people who have procoagulant states. So it's again a very common kind of headache. It's also a sort of a thunderclap headache. Here again, they could lose their vision. So it's very important to rule out these causes. So subarachnoid, so intracranial hemorrhage. So that is one of the reasons why people get an MRI or a CT scan done for these patients. And sometimes you need to have a high index of clinical suspicion. Also, you need to rule out tumors like a neoplasm, cerebral tumors, pituitary tumors can cause headache. Severe infections like meningitis and encephalitis can present with headache, and very rarely intracranial abscesses can present with headache. So you need to rule that out. Similarly, in the elderly, a subdural hematoma, a chronic subdural hematoma can present with recurrent headaches. Glaucoma can present with headaches. That's why we need to get the eyes checked for most patients. And very rarely in the young age group, we can see benign intracranial hypertension. It is not benign because if it's where there is an increase in the intracranial pressure due to various causes, and if it's not treated aggressively, then it could lead to loss of vision. So what are the things that are often missed or the pitfalls? So you often miss cervical spondylosis, cervical myelopathy, cervical dysfunction or radiculopathy. We also miss out the dental disorders. So you remember that in your head, the teeth are also there. So you need to have an oral examination of these patients, refractive errors or eye problems, sinusitis, herpes zoster ophthalmicus. We often we need to realize that before the eruptions of herpes, you could have severe pain. Then there are the various kinds of exertional headaches, exertion induced, like when you do a lot of heavy exertional activities, hypoglycemia, post-traumatic headaches after a spinal tap, and sleep apnea. Elderly people who are obese, they are prone to get sleep apnea, and that itself can cause headache because of the hypercarbia. Then you have headaches after Paget's disease, Cushing's syndrome, Conn syndrome, autonomic issues are there. And also it can be very rarely seen after coitus or sexual intercourse. So these are the very rare causes of headaches. So the more common causes I've already said, but you need to consider this. So just remember the face. So you have the neck, you have the tooth, you have the ENT, the eyes, the nose, the throat, the ears, etc. And then you have the skull. So you close your eyes, visualize the entire head, you would be able to rule out one cause after the other. So what are the mimics? One mimic is depression. Very rarely drugs. There are various drugs which can cause headaches, so you need to ask for history, especially the antidepressants can cause headache. A lot of the neuropathic pain medications can cause headache. Cardiac medications can cause headache, like nitrates. Very simple cause. A lot of patients may be on cardiac medications. Ask them a history whether they are on cardiac medications. So that's one thing. Sometimes calcium channel blockers like amlodipine can cause headache for patients. So a simple antihypertensive drug can cause headaches. You also need to rule out endocrine problems. As I said, there is a variety of endocrine problems which can precipitate with headaches like Cushing's syndrome and Conn's syndrome, etc. Spinal cord problems, recurrent infections like UTI, respiratory infections can also cause headaches. Very rarely, hypothyroidism and hyperthyroidism both can cause headaches. And finally, you need to rule out psychogenic causes. So, a lot of patients may have psychogenic headaches. They may be always complaining to you, it may be functional. So, what are the timelines? So, acute headaches usually indicates a subarachnoid hemorrhage. It could be a exertional headache, or it could also be a migraine or a cluster headache. A subacute headache, which is of recent onset and increasing in severity, it could be because of an intracranial lesion or it could be due to temporal arteritis. If you get recurrent episodes of headache, again, it could be a migrainous headache or a cluster headache, or it could be an exertional headache or a neuralgic headache. Trigeminal neuralgia can very rarely present with pain around the face. Chronic headache can be because of tension type, it can be transform migraine or rebound headache, and very rarely cervicogenic causes can cause a headache. So you need to know the time. So the onset is very important. The duration of the pain is also very important. And then you have the patterns. So migraine is like typically it starts in the morning and builds up, you know, in the early mornings and then reduces in intensity by evening. Cluster headache typically peaks at night and in the evening. Sinusitis happens during the daytime. The maximum peak is around like 12 noon. The tension type headache is low grade headache, which is present all throughout the day. And then usually during sleep, it reduces in severity. Depression is slightly different. It is indolent all throughout the day, but again at night it peaks. Then you could have cervical spondylosis, where again it interferes with your sleep. So there's a severe pain at night or early in the morning. Tumor again can cause pain late at night. So the patient can often wake up at night with severe headache, and that could herald the onset of a cerebral tumor. So, as I said, we have a clinical approach to that. We need the patients to describe their headache. What is the intensity of the pain? What is the profile? How does it build up? What are the other symptoms like headache, nausea, vomiting, etc.? Migraine headaches without nausea and vomiting is very uncommon. Without the sensation or the uneasiness is very uncommon. Whether there are any auras, any blurring of vision, any watering or redness of the eyes. Does the patient have any cutaneous allodynia, so they have any pain while combing their hair? Is there any stress? Is there any cold or flu-like symptoms? Because that then heralds the onset of sinusitis. Is the patient on any medications? Is there exposure to high temp? Means is there fever, sweats, chills? Is there recurrent URIs? And is there history of trauma? Also, I like asking history of travel, air travel, especially if people are coming from a high altitude area. So you can get altitude related headaches. So that's another thing that you need to rule out. So examination, again, you just need to examine the patient clinically. You need to look at the vital signs. You need to examine the patient. Look for the fundus. It's very important. Look for the vision. Look for the ear, nose, throat. As I said, just remember the entire face and the oral cavity. You will be able to reach a diagnosis once you localize or once you do a meticulous examination of these patients. There are certain special signs. So the first one sign is we look for the upper cervical sign, the upper cervical pain sign, where patient has severe pain around the C1, C2 region. So patient may have basically a pain as well as severe tenderness around that region. Then look for the Ewing sign for frontal sinusitis. So press around the supraorbital ridge, and if the patient has severe pain, it indicates frontal sinusitis. And you can also look for the invisible pillow sign. So when the patient is lying down, he'll keep his head very guarded, as if he's on a pillow, and that usually indicates that he could be having a cervical muscle spasm or cervical spondylosis. Yeah. So there are certain red flags, and these red flags are very important for us to realize as to what the other causes are. So, is there a sudden onset of headache? Is there a severe debilitating pain? Is the headache progressive in nature? Is there associated fever, vomiting, alteration in consciousness, changes in personality? Is it worse with change of position? Is it maximum in the morning? Are there any other associated neurological signs, visual symptoms, and visual signs? Is there an associated seizure? Is the patient a young obese female and she's on medications, like, for example, tetracyclines, steroids, patients on anti-acne medications and hormonal pills? All these can predispose a person to get headaches, especially BIH, benign intracranial hypertension. Any new onset headache in the elderly needs to be evaluated, and after a head injury, you need to evaluate it. So as I said, the red flags are based on physical examination. So you look for the physical examination, look for alteration in the consciousness and the cognition, look for signs of meningitis, look for vital signs like high BP, temperature and respiration, and focal neurological signs like pupils, fundus and eye movements. And then the look for the tenderness of the temporal arteries. So that's very important. When we do the investigations, we basically do a CBC, just to look for leukocytosis and infection. Always get an ESR and CRP done, because a temporal arteritis presents with high ESR and high CRP. Treatable condition, responds well to steroids. Or get an X-ray chest done to rule out the METs to the brain. Cervical spine X-ray, skull X-ray may be needed, and sometimes sinus X-ray, but nowadays we don't do it. We just do a CT scan of the sinuses. Again, CT scan is effective to rule out subarachnoid hemorrhage and a cerebrovascular accident. It can also pick up a tumor. MRI is very sensitive. MRI gives a better anatomical definition, and also the structures are better visualized on MRI. So if you ask me which investigation I will prefer, I'll prefer an MRI with contrast, because in that you rule out everything. You rule out vasculitis. You also rule out, cerebral venous sinus thrombosis. You rule out space occupying lesions. And if you're suspecting meningitis or a subarachnoid hemorrhage, then you should do a lumbar puncture. Should take care that there is no there is no increase in intracranial pressure, as it could lead to herniation and coning. But still, CSF is always on the cards for patients to rule out other causes. So when we look at the age-related causes of headache, in children, it's intercurrent infections, psychogenic, migraine, meningitis, and after trauma. In the adults, it's migraine, cluster headache, tension-type headache, cervical dysfunction, subarachnoid hemorrhage, and it could be a combination of the above. In the elderly, it could be cervical dysfunction, tumors, temporal arteritis, neuralgias, Paget's disease, glaucoma, cervical spondylosis, and subarachnoid hemorrhage. You can see that in children, it's more of infections, and there is an onset of migraine, more of infections, more of trauma, more of psychogenic causes. In adults, it's more of the primary headaches that are there. And in the elderly, it's again more of the secondary causes of headaches which are there. So we can see that it's more of primary, which is there mainly in the adults. So that is the meningitis, etc., are more common in the elderly, and they are more common in children. Whereas like migraine clusters, etc., are more common in adults. Okay, so let's look at Some of the common causes of headache. The first one is the tension type headache, very commonly seen in our practice. Basically, it's a band-like sensation. The patient actually complains around the head, or it's like a helmet-shaped headache. It's also called as a muscle contraction headache, symmetrical, lasts for hours, recurs every day on a daily basis. There could be cervical pain, stress, as well as tension, more common in females as compared to males. So when we look at the criteria, you need to have at least like 10 of these headaches. It should last for half an hour to up to 7 days. Usually non-pulsating, mild to moderate in intensity, bilateral. There's not much of nausea, vomiting, photophobia, auras, etc. These are absent. So it's basically a simple headache which is persistent and a dull aching headache, more of a band-like sensation or a constricting sensation around the head. That's the classical tension type headache. The sites are frontal and over the temples. It radiates to the occiput. The patient feels like he's having some heavy weight on his head. Classically, he tells us that sir bhari lagta hai apna. It occurs every day, and it starts when the patient wakes up in the morning and gets worse as the day progresses, reaches a maximum peak by evening, but the patient is able to sleep. There are aggravating factors like stress, overwork, skipping meals. Relieving factors include alcohol. There could be associated features like neck pain, neck spasm, lightheadedness. And as I said, you could have the invisible pillow sign. So how do you manage this? So basically, you ask the patient to have stress reduction, cognitive behavioral therapy, counseling these patients, do a lot of exercise, you know. So that's one thing. And a lot of times, a simple painkiller like paracetamol works well for these kind of headaches, and you can add it with a muscle relaxant. A simple muscle relaxant works well. And usually, once the trigger is removed, these headaches go away for these patients. Then the next common problem that we face in our OPD is migraine. So we all know about that. Typically, it's a unilateral kind of headache, maybe retroorbital, involving one side of the head, maybe bilateral at times. So we need to realize that patient is sick more in females as compared to males. So you have like two types. You have the classic migraine and the common migraine. So in classic migraine, aura is there. In common migraine, there is no aura. And the most common trigger factor is stress. So there are various forms of migraine that we see. I mean, we have the common migraine, classic migraine. We have complicated migraine where they have hemiplegia, ophthalmoplegia, etc. Then we have the retinal migraine, basilar migraine, migraine equivalence. Migraine is also a very common cause of dizziness. You need to realize that it can be associated during your menses. Then there are these ice pick headaches. And then there are the other primary headache disorders, which are also called as cluster headaches and the paroxysmal hemicrania. So we have the various kinds. Commonly, you have a lot of stresses like food stuff. So it's chocolates, oranges, cheese, pastas, pizzas, red wine. There are drugs. Then there are things which contain like monosodium glutamate, OC pills, bright lights, emotional stress, head injuries, change of climate, change of noise, strong perfume, etc. So you acquire triggers. So, this is also too much of sleep, too little sleep, too much of exercise, too little exercise. So you acquire triggers along the way. But the commonest triggers are the food and environmental triggers. Then you have other endogenous triggers like you have features like fatigue, physical exhaustion, oversleep, lack of sleep, stress. Then you have a weekend migraine. So basically, migraine is classically seen at the end of a stressful period. So students who go for the exam never complain of headaches during the exam. The headaches always come after the exam is over. Or people who go to work never complain of headache during their working days. They always complain of headache during their weekends when they are relaxing. So it's also called as a weekend migraine. And then hormonal changes, hunger. So hunger is a very common trigger. People who are on empty stomach, they get recurrent headaches, and also personality things. So as I said, there are certain features that you need to know. It's usually retroorbital, maybe unilateral, very rarely it's bilateral. Mostly it's frontal. It could also be occipital, throbbing in intensity. The duration lasts from 4 hours to 72 hours. And there are fluctuations basically. As I said, there are precipitating factors, there are relieving factors. You feel better once you sleep, you feel better once you go to a dark room, you feel better once you vomit. And there's a lot of irritability and stress associated with it. So we have basically the criteria. In the criteria, you need to have at least 2 attacks. Then you should have reversible aura-like symptoms. It could be associated with speech problems, sensory problems, and vision problems. And the aura needs to be there, and the aura needs to last from 5 minutes to 60 minutes. And the headache should follow the aura. And you should also rule out all other causes, including strokes and TIAs in these patients. So that's why imaging becomes very important in these patients. Again, for a common migraine, there is no aura. It's usually unilateral, usually pulsating, and it's moderate to severe intensity, but it's associated with nausea and vomiting and photophobia and phonophobia. Again, it should not be attributable to any other disorder. So how do you manage migraine? Typically, you manage migraine with counseling and advice. I tell my patients that once you have a migraine, the attack is not going to go away. You're going to keep having attacks again and again. You need to change your lifestyle along. You need to also know how to treat an acute attack for these patients and how to treat a severe attack. And then you have to plan long-term prophylaxis for these patients. So aspirin works well or paracetamol works well in an acute attack. Cold packs to the neck and the forehead. You avoid tea, coffee, orange juice. Avoid moving around. Avoid reading. And avoid watching a lot of TV. A lot of patients prefer to sleep off the attack. So you could give them a small dose of benzodiazepines. In India, I prefer giving clonazepam. It works very well. Just they can sleep off the headaches. And if it's a moderately severe attack, you can give an ergot or a triptan. And as far as possible, we avoid opioids because of the risk of medication overuse for these patients. So again, when we look at the first line treatment in acute migraine, we usually start with an aspirin or a paracetamol. We give an antiemetic, or we can give a non-steroidal anti-inflammatory drug. Ibuprofen is good enough. Naproxen is very good enough, and then we give triptans. So sumatriptan is available as an oral medication. You have zolmitriptan available as a nasal spray. You have naritriptan and rizatriptan available as an oral tablet. So, and elitriptan, which works on a longer duration. So, in such situations, you need to choose the triptans. Traditionally, I use either zolmitriptan, which is available as a nasal spray, or I use sumatriptan like tablets, which is available in combination with naproxen. Very rarely I use a combination of naproxen and rizatriptan. Again, one problem about the triptans is that rebound headaches are very common. Patients also, you know, have a lot of emesis and vomiting with the triptans. So you need to be careful with that also. So how do you treat a severe attack? In a severe attack, you have to give them a painkiller like a triptan and an analgesic. So you have to give an analgesic with a triptan. Metoclopramide works very well, but again, abuse of metoclopramide, which is commonly available by the brand name of Stemetil, is associated with a lot of extrapyramidal side effects. Chlorpromazine may help. So you need to give a combination of an ergot with a painkiller or a triptan with a painkiller. Okay. One thing which usually works is giving the patients metoclopramide with a large amount of fluids with an oral painkiller, and improving the fluid intakes also helps, because patients may be vomiting all the time, patients may be puking all the time. They may be extremely dehydrated, and they go into a vicious cycle where they get headache, nausea, vomiting, dehydration, and then this keeps repeating again and again. So there are some patients who go in for something called a status migrainosus. So that means recurrent attacks of headache, intractable headache, which last for more than 72 hours. So in such situations, we give IV steroids, chlorpromazine, and IV ergots. All these work very well. Steroids are very easy and easy to give for such situations and works well. So how do you give the prophylaxis? So prophylaxis, there are various drugs for prophylaxis. One commonly used drug is beta blockers. Propranolol works well. Tricyclic antidepressants like amitriptyline works well. Anti-epileptics like sodium valproate and like topiramate works well. Again, when you're giving topiramate, you need to be careful about glaucoma, and you need to be careful about renal stones. Yep. So that's one thing. And then you have menstrual migraine, which again you can treat with naproxen, which works very well. And very early you can give estradiol gel for the patients, which lasts, transdermally once daily for 7 days. So there are other drugs that you can give. You can give like pizotifen, beta blockers, amitriptyline. Again, if there's like cervical spondylosis, you can again give amitriptyline with naproxen. And if there are some food sensitive like migraine, you can give the patient like pizotifen. So there's a combination of drugs that you can use, but preferably, I know a lot of people like using the calcium channel blockers like flunarizine or sibelium as it's known, but you need to use it with a lot of care because it's associated with side effects, weight gain, depression, psychiatric problems, extrapyramidal problems. Propranolol works very well with a combination of amitriptyline, that's a good drug, or a combination of sodium valproate, that's again a good drug, so which works for these patients. So what are the take-home points? So number one is you need to find out what is the type of headache. You need to diagnose the headache, rule out secondary causes, rule in primary causes. If it's a tension type headaches, mainly you need to reassure the patient and lifestyle changes. If it's migraine, you need to know how to treat an acute attack, how to give prophylaxis. So acute attack treatment is totally different from prophylaxis. In prophylaxis, you give daily medications to reduce the severity and frequency of attacks. Whereas in an acute attack, in prophylaxis, you give everyday treatment. In a prophylaxis, you give treatment to reduce the severity and frequency. In an acute attack, you just give treatment to abort the current attack. It doesn't do anything for the future attacks. You need to know that. इधर का time खत्म हो रहा है, just. So, as I said, there are other things that you need to know. In like migraine, the family history is usually positive. The onset is usually in the teenage group. You have a prodrome. Whereas in a tension type headache, mainly the headaches come around the 30s and the 40s. Unilaterality more favors a migraine. Constant headaches more favor a tension type headache. The frequency of migraine is usually episodic, so it occurs once every 4 days. The associated vomiting, aggravation by alcohol, aggravated by the pill, etc. All these favor migraine. So, in general, headaches are a heterogeneous group of disorders. You need to know how to differentiate the various causes. The role of imaging is mainly to rule out secondary causes, to rule out infections, to rule out vascular causes. And uh, once you make the diagnosis of a primary headache disorder, you should know how to treat these patients. You should know how to give prophylaxis for these patients. You should know how to manage them. There's a lot of lifestyle changes which patients need to do and which our patients don't do. Nobody, you can manage a lot of headaches by taking care of the weight, by taking care of um you know uh, with regular exercise, with regular cardiac exercises, by actually taking care of the food, eating frequently, eating a healthy diet, the triggers which are present in the diet. So most of the primary headaches are actually treatable. Another thing you need to know is cluster is something seen more commonly in men. It has a seasonal, so it occurs in clusters. So patient will have headaches for 15 days altogether, then there'll be no headaches. Then again headaches come for 15 days. You need to identify it, and it needs specialized treatment by a neurologist. So, in general, this was just a brief summary of headaches and how to go about it. So, as I said, you all should all know how to differentiate between a sinus headache, a tension type headache, and a migraine. You should know how to rule out secondary causes of headache. You should know the value of imaging. You should know when to ask for imaging. You should know when to give steroids and other treatment in order to rule out something like a temporal arteritis. So, very important, very easy, and but if you systematically approach it, you can treat it. So you should know, imagine, as I keep saying, close your eyes and imagine the head. All the structures that are there in the head can be involved in headaches, and they can be a cause. So you need to have a high degree of suspicion and a good level of clinical examination to make diagnosis of headache disorders and treat them accordingly. So, for example, if the patient is having trigeminal neuralgia, the headache may radiate to the temple region. But if you don't ask for history of trigeminal neuralgia and you are giving the patient flunarizine and propranolol for migraine, it's not going to work. You have to give the patient carbamazepine, phenytoin, like lamotrigine, gabapentin, amitriptyline, etc. Similarly, if the patient has herpes zoster and you have not looked at the zoster, it's going to be missed. Similarly, if the patient has sinusitis, you've not got a CT scan done of the PNS, you've not given the patient, a steroid nasal spray and an antibiotic, the headache will not go away. So you need to have a high degree of suspicion and a good clinical acumen to treat these patients. So with that, I conclude my with that, I conclude my talk. I've almost spoken for 40 minutes on this topic. If there are any questions on the house, I would be glad to answer them. And if there are any treatment related issues which need to be sorted out, again, I would be glad to sort it out for you. Okay, thank you. Only 3 minutes are remaining. So there is a very good question asked by Dr. Court, who's asked, how soon can we taper beta blockers used for prophylaxis? Usually prophylaxis need to be given for at least a period of 3 months. 6 weeks is the minimum period of time, but it needs to be given for 3 months. And then you start like tapering. Again, if there is a recurrence, patient is doing well on beta blockers, you can continue it for a long duration of time. It's not going to cause any problems. Uh, the second question which has been asked is, in migraine headache, which medicine works best? So if it's an acute migraine, the best thing is to give a non-steroidal anti-inflammatory drug. I prefer a dispersible tablet of Voveran, but again, you should be worried about the kidney. The other drugs, uh, so the other drugs which are used include naproxen, commonly used by the brand name of Naxdom. Combiflam works well. Simple like paracetamol works well. Ultraset, which is tramadol, also works well. So you could, a lot of times patients actually develop a resistance to a lot of these drugs. So you need to you need to see what works, what actually works very well for them, and you need to use that only on an SOS basis. If you take a lot of painkillers, you develop something called as medication overuse headaches. Painkiller is used to abort the attacks. Triptans are used to abort the attacks. Ergots are used to abort the attacks. The long term is with lifestyle changes. You control your diet, control your exercise, do cardio exercise, running, gym, swimming, etc., and then bring down the frequency and intensity of the headache. Another very good question: what is the role of lumbar puncture? Um so there is a so if it's a new onset of headache, I would do a lumbar puncture. you know if it's a new onset of headache, I would do a lumbar puncture, because It will rule out, things like a meningitis or TB meningitis or a subarachnoid hemorrhage, etc. It means it can rule out. If it's a chronic headache, I would not be doing, basically a lumbar puncture for these patients. And once imaging is normal, so again, a contrast imaging becomes very important. In a lumbar puncture, a lot of times we also measure the opening pressure to rule out benign intracranial hypertension, which is again very important. There's another question which has been asked on the role of triptans. So triptans are better. Triptans basically help to abort the attack. And there are various forms of triptans, sublingual preparation of triptans, intranasal spray of triptans are available, oral tablets and injectable triptans are available. So triptans are very effective. The only problem is, again, the abuse of triptans are there and it causes a rebound headache. You should give the triptans as soon as the headache starts, and it's a very effective treatment option for management of migraine. Yeah. For acute